Hello, good afternoon from Switzerland. Welcome to our webinar, AVM, Application and Ventilation Training. My name is Christian Remus. I'm Product Manager of bellavista, and on the opposite side of the table is Janessa Ratazzi, which is responsible for all this technical stuff and the production for today. Today is the second part. 14 days ago, we had the first part with the basics of AVM and how AVM is called, what it means, and what is closed-loop ventilation. Today we go one step ahead and talk about the application of AVM and talk also about the strategy, how and when to use AVM. And let's start right away. First, for all those who visit us the first time, just to explain the user interface of the GoToWebinar software. You can chat or you can raise your hand if you have a question. You can chat and ask questions, and you can also ask per audio. If your computer supports this feature, you can ask questions whenever you like. I try to look at the questions that pop up during my speech, but at the end of the webinar, you can also ask questions and I will try to answer them. Okay, first for those people who weren't there, attended not to the webinar 14 days ago, I will just summarize what we discussed there, just a few bullet points. So the AVM is a pressure controlled mode, but additionally, we call it also an optimum target ventilation mode. That means AVM is looking for an optimum target, and you set just the minute volume, and AVM is looking for the optimum in this desired minute volume you set. The algorithm is intended to ventilate all kinds of patients, from intubation up to extubation, because spontaneous breathing is promoted and is allowed all the time for the patient. AVM, the algorithm, is mainly responsible for ventilation. That means CO2 is part of the ventilation. So everything you do with the special AVM settings is just for ventilation. You have to put FiO2 and PEEP manually to adjust oxygenation for the patient. For the best practice, you need to type in the ideal body weight. In the bellavista, you have to set the height of the patient, and the ideal body weight calculation is done by bellavista. But for several reasons I explained last time, it's very important to set the height correctly so that bellavista is working in the best way possible. The optimum target point, which the algorithm and the so-called Otis equation is always looking at, is the least work of breathing. So the Otis equation is just looking for the expiratory time constant, is calculating a respiratory rate and divided, the respiratory rate divided by the set minute volume is the optimum tidal volume and respiratory rate. And there are additional lung protection rules which prevent the patient from unphysiologic settings, which means it prevents barotrauma, it prevents auto-PEEP, it prevents dead space ventilation, and it also prevents apnea. So this is the reason why there is a lung protective window around the optimum target. Okay. First, the question before we start, we really start with the second part today. Who has experience in working with AVM? We have 4 answers provided for you. You see here. We use it for most of our patients, so you have experience. We mostly use it for post-surgery patients. You have heard of AVM, but you never have worked with AVM, or you have never heard from AVM before, and you really don't know what you're doing here today. But all of you are welcome, so let's see where the answers go to. And the poll is open now, and we are collecting the answers. And we will have a result in around 20 seconds. I just need to know because in the morning we had some interesting results. Nearly 30% already had some experience with AVM, which is very good. And the other 70% maybe would like to work with, but didn't have the opportunity to. So let's see. Okay, this looks quite clear. Most of you also heard of AVM, but never worked with it. But that's the reason why we do the webinar. And so we'll go ahead. And some more reasons to use an optimum target or closed loop ventilation might be these, if you have a look at it, that if there is a higher workload in the field of ICU, lots of errors increase. 45% of all errors done in the ICU are directly connected to ventilation. So this is a big issue, and you see all this workload stuff and burnout and everything else is just about lots of different devices, lots of settings nobody really understands. And AVM is just also trying to reduce the workload so that you don't have to do additional settings for ventilation, and the controller and the computer and the ventilator relieves you from settings, and that's the intention of AVM. Another reason is also that healthcare is getting more and more expensive, and you see also that 15% of all the patients ventilated end up in a ventilator-induced lung injury, and these causes additional costs, around an average $1,500 a day. And ventilator lung-induced injury is all around $57,000 a day. And so everything we do and we try to do is more and more adaptation for the patients in our ventilators, and maybe reduce the number of errors, reduce the number of manual settings, and also maybe reduce the cost. Okay, now we really start with the ventilation. By starting with AVM, there are first 3 test breaths with 15 centimeters of water just to measure out the lung condition. And after 3 breaths, we have all the data we need to adapt the ventilation directly to the patient. Just for reconsidering, in terms of settings you have to do, if you have a mode like PC-SIMV, which is a pressure control SIMV mode, these both values are responsible for the ventilation. So these are already 2, because you have to set the pressure support and you have to set the inspiratory pressure. And there's also the timing parameters. You have to take care about the rate and also the inspiratory time. And if the patient changes or the lung condition changes, you need to adapt those values. And third is oxygenation, PEEP, and FiO2. And just to see what you have to do with AVM, you have the ventilation, you set 1 minute volume, and so the minute volume is kept stable for the patient, but all the timing parameters are integrated in this setting, so you don't have to care about the timing parameters anymore. And of course you have to adjust the oxygen, still the oxygenation. But you see already a lot less controls by setting up the ventilation. Okay, now we'll change to bellavista and demonstrate how to set up bellavista and how to work with AVM and what happens if we change settings, for example. So we go to the demo. You see here, this is the cockpit screen. On the upper side, we have the animated lung. I did this for a reason, just that we can compare the lung condition of the patient with the lung protection window of bellavista, of AVM. And you see that we have 100% minute volume for a patient which has an ideal body weight of 57 kilograms. That means, last time we learned, times 100. At the end, it's 5.7 liters per minute. And that means this patient should be, if the lung is healthy, should have a regular CO2 washout. And you see already the minute volume target is 5.7, and to the right, the expiratory minute volume is now around a bit over. Now it's 5.77. So bellavista nearly reached already its target. And you see also that the target tidal volume and the expiratory volume is in that range, more or less. You also see that the expiratory tidal volume per kilogram is around the desired and also recommended 6 milliliter per kilogram. And at the right side, you see the expiratory time constant, which means how fast can the patient exhale. And this is very short because the patient, or the resistance of the patient, is very, very low. And that means the patient doesn't have any problems. The lung currently is quite healthy. And now you see bellavista has adapted the respiratory rate of 16 and tidal volume around 350. So now I'm doing a blood gas analysis, and I see, okay, CO2 is a bit too high. What do? I increase the minute volume. And I do this by 30%, which means we don't have 5.7. Now it's 7.4. Look at the graph. The curve has changed. And now also the minute volume has changed, and bellavista or AVM is already adapting. So in this case, regarding to the current lung condition, the tidal volume didn't change very much, but the respiratory range changed by 4. This means AVM decided, because of the lung condition of the patient, it would be better to just increase the respiratory rate because the expiratory time constant is very low. The patient has no problems on the expiratory side. You also see that the inspiratory pressure is 11, which is quite good. And so we could ventilate forever. So now I'm changing the time, and not the time constant, I'm changing the lung condition of the patient, and then some other things will change, and I decrease the compliance of the patient. You will see that there will also be a change. So now it's recalculating. See also that the inspiratory pressure is now going higher because the compliance is decreased. And that means for 7.4 liter, it needs to adapt with a much higher pressure than before. And to reach the 7.4 liter, it's increasing the respiratory rate, but also decreasing the tidal volume. And that means the patient wouldn't like to have a higher tidal volume, but regarding to his expiratory time constant, it's very easy for him to get used to higher frequencies. So now you see bellavista already adapted, and now I'm changing the compliance again. And you will also see that now the respiratory rate changes again, and this is done breath by breath and all the time. So now you would maybe ask, what would happen if a patient has an obstructive problem? So this problem is not anymore the lung compliance, it's more the obstructive side. And now I changed the resistance of the patient. So now you see that this window, which was before very rectangular, is getting more and more square. And now the tidal volume increases and the respiratory rate decreases. That means, and now you see here, the expiratory time constant is also rising. So that means this patient did much more time to exhale, in this case 5 times to 6 times longer. And that means the patient needs more time to exhale, so the respiratory rate can't be that high again. And so now it's ventilating instead of 22 respiratory rate with a respiratory rate of 15, but also with a higher tidal volume. But the compliance of the patient now is quite high, so it can allow to ventilate with a higher tidal volume. But at the end, you will always have 7.4 liter, maybe not currently, because now he has to adapt the minute volume. But it will get there if you give it a bit more time. But you see now the lung protective window is getting smaller and smaller. And that means maybe at some points you have to make a decision if you want to increase maybe the pressure limit, or if you now decrease the percentage, so it's not 7.4, you see the window will get bigger again, because now bellavista is not forced anymore to ventilate with 7.4, only 6. And just to demonstrate, if I go back to 80%, and now you see for this patient, the respiratory rate is very low, because now I have 2.6 seconds of expiratory time constant, which means that this patient needs around 7 seconds to exhale fully. And it's still adapting, but now it's run out of possibilities. So I adapt also the resistance. So now you see the window gets bigger, and the possibilities for AVM to adjust are getting higher and higher again. But you see that it's really depending on the expiratory time constant. When the expiratory time constant is very short, you will find low tidal volumes and higher respiratory rates. And the expiratory time constant is getting longer and longer. The tidal volume will get higher, and the respiratory rate will get lower. So now we're going back to normal conditions. Now you see that the window is getting bigger and bigger, and this always means that your possibilities for AVM to adapt are getting bigger and bigger too. And now you see that all the values already normalize, and that AVM is still adapting. Usually, patients do not change their lung conditions like I do in seconds. It takes some more time, so the time for the ventilation mode to adapt is much longer. And what I always also wanted to show is now if the patient decides to breathe spontaneously, he can do it anytime he wants. And you see that this patient is, just adapt the pressure here. You see that the patient can breathe, and if the patient wants to stop breathing, he can just do it. The ventilator will take over after a few seconds with the next mandatory breath. So there's no apnea backup ventilation necessary. AVM will always do the job 100%. Okay, we turn back to the presentation. And I will just summarize what I showed you before about spontaneous breathing. You see now the curve and the target point. The patient it's always possible for the patient to breathe spontaneously whenever he wants to, and it's always supported breath. So AVM doesn't allow unsupported breath. That means the lowest pressure support AVM is giving you is 5 millibar centimeters of water. So it doesn't go lower than that. And It depends on if the patient is breathing strong, then the tendency is to reduce the pressure support, and if the patient is breathing shallow, the pressure support will be increased. When the patient is breathing shallow or is breathing with a higher minute volume than the set target volume, you can support this patient if you want to support him. If it's not a patient who will be extubated in the next few minutes, then you can adjust the minute volume, because maybe patient target is 7 liters, patient is breathing 10 liters. Don't reduce the target volume, increase the target volume and go near the current spontaneous minute volume. And then the patient will be more and more supported. And because when I see users working with AVM and the patient is breathing spontaneously and they don't want that the patient breathes much over the target, just remind that the target is something you set, and it's maybe not that what the patient wants to have. And if the patient needs 10 liters of minute volume, you should give him the 10 liters and not punish him. So increase the minute volume. Do not decrease the minute volume to get the patient back to target, because target is something you set, not the patient. But you can also do this for weaning. If the patient starts to breathe spontaneously and you want to expedite weaning, you can set, okay, I go a bit below the current minute volume just to keep the patient in stable conditions and to let the patient breathe spontaneously. Because if you increase the minute volume too much, the patient gets too comfortable. Some patients would say, okay, when the ventilator is doing all the work, I'm going back into the hammock and lay back and don't do nothing else. So just keep the patient in work when you want to wean the patient and when you have a goal to extubate the patient in very soon time. But always watch for signs of dyspnea. The patient shouldn't be exhausted on AVM. So this is the controlling job you have to do when working with AVM. The other situation is you have a mostly post-surgery patient. The patient is already awake and you can communicate with the patient, but he's not breathing. And that means, as I said before, he's very comfortable. He doesn't see any reason for breathing spontaneously because the ventilator is doing his job. And AVM is doing the job quite well, so why should I breathe? Also, reduce the minute volume so that CO2 will increase a bit and the patient needs to get rid of the CO2 by spontaneous breathing. I would also recommend, if a patient is coming from surgery and he's lung healthy and has no other problems, not to start with 100% of minute volume, maybe to start right from the beginning with 80 or 90% to keep the CO2 a bit more above normal so that patients really start to breathe spontaneously as soon as possible. When the patient is breathing spontaneously and he seems to be stable and he seems to be comfortable, you can start a spontaneous breathing trial, and you can achieve this very easily by reducing the minute volume to 25, 30 to 40%. So the support from AVM is very low and the patient has to do most of the work. And then you can decide after 30 minutes, 40 minutes that the patient can be extubated. And this is very important. The percentage of minute volume doesn't tell you where the patient is. The patient can be high above the set minute volume. The patient can be exact on spot of the minute volume and breathe 0, and he can be highly above and breathe 100% spontaneous. So there is no goal for the minute volume. If the patient is stable and is breathing spontaneously and everything is fine, it doesn't have to be 100%, 80% or 120%. It doesn't matter. As long as the patient is stable and fine, it's no use of, oh no, I want to extubate him and I'm still at 120%. I have to reduce the minute volume. This is too high. No, that's not the case. The spontaneous activity and the condition of the patient is not related to the setting of the minute volume. This is a kind of guide. It's a clinical decision chart, and it's maybe helpful to always remind what you can do, how to work with AVM. If the patient has dyspnea, or the PCO2 is above normal, or the PO1, which is an indicator for spontaneous breathing, is bigger than -3 centimeters of water, which means that the patient is very strongly breathing and he's in need of air and support. When you can answer these questions with yes, then you have to increase the minute volume, as I said before. And when you have increased the minute volume, go back to start, wait maybe for 30 minutes, and then you ask the same questions again. If the questions can be answered with no, then you can start your weaning process. And then, is the patient breathing, yes or no? If yes, reduce the minute volume, not by 50%, maybe just a slight bit, and start your process again and to question you. If you can answer the weaning question with no, then just wait that the patient is stable for 60 minutes. And after 60 minutes, and the CO2 always has to be in a normal range. If the patient is not stable for 60 minutes, it's like Monopoly, go back to start. And then you have to ask the same questions again. If the patient is stable for 60 minutes, you go to the next step and just check the oxygenation, because you can't extubate or consider extubation when the oxygenation part is not good. So if when the oxygenation is sufficient, it's either yes or no. When it's no, go back to start and look for the oxygenation. When the oxygenation is sufficient, then you have to look if the weaning has progressed and if the pressure support is constantly below more or less 10 centimeters of water. When it's not, go back to start and then do the whole thing again. And when you reach a point where you can say yes, you can consider a spontaneous breathing trial. Of course, this is just a chart. I can never imagine all the situations you will find in the clinical setting, and this doesn't replace the opinion or the decision of a clinician. And there are so many explanations from that, so that this is just not even a recommendation, it's maybe a strategy how you can do the steps working with AVM, so this might be helpful. But of course, it can be totally different, and sometimes patients are doing differently than any chart in the world, but maybe it helps a bit. And for the end, the implementation of AVM, if some clinics are interested in, we would like to start with AVM, there are some rules to follow, and the most important one is everyone in the team should learn something about AVM. If the nurses are excited and want to use AVM and the doctors are not convinced, AVM won't be a success. So all should be inside this and all should be trained on AVM. If not, in my experience, it doesn't work very well. And it always works very well when you start with lung healthy patients just to start with and to get experience. And then later to start with a patient with more difficult lung conditions and severe pneumonia or ARDS, or on the opposite side, COPD. And this is really important because when you have an ICU, you have a ventilator guidelines or strategies, adjust these protocols to AVM, because AVM just works a bit differently and it just reduces settings, and if there is some guideline which is not adapted to AVM, this won't be a success either. Okay, this is the end of the presentation, and the PDF of the presentation is online now, so that you can download the presentation as a PDF. There are some questions about the lung conditions of the patient. As I showed you, is it possible to work with AVM and COPD? Yes, it is. As I said in the last webinar, there is no lung condition where you should prevent AVM from ventilating. And it's for COPD patient, it looks at the right respiratory rate just to prevent auto-PEEP, which is not good for those patients, because this prevents a good weaning. Because the patients may have more work of breathing just to get over the auto-PEEP. So AVM prevents this, and the patient always has enough time to exhale. And the same for ARDS or restrictive patients. They are always taken care of, because it really is looking for the least work of breathing, and that means that guarantees low tidal volumes and adaptive respiratory rates. Okay, so there are no more questions, but if there are some questions, you can raise your hand, you can ask. Still there for answering. So everything understood, fine. Okay, so then we are at the end. Thank you very much for your attention. I already told you about the PDF. You can also ask for more topics of the next webinars. You can also give a thumbs up or thumbs down for this webinar. And I hope to see you next time. Bye.